So it's my pleasure today to introduce to you Dr. Charlesnika Evans. Dr. Evans is one of my primary collaborators at the VA in my health services research center that I work for at the Hines VA. So Dr. Evans is a research health scientist with the VA HSR&D at the Center of Innovation for Complex Chronic Healthcare. She's also an associate professor in the Department of Preventive Medicine and the Center for Healthcare Studies in the Institute for Public Health and Medicine at the School of Medicine at Northwestern. She has a bachelor's degree in microbiology, hence we have a lot to talk about, a master's in public health, and a doctoral degree in epidemiology, which she received here at the University of Illinois at Chicago. In 2012, she was one of 96 recipients in the entire country to receive the Presidential Early Career Award for Scientists and Engineers, and I believe she was the only VA researcher that year to receive the award. And I think that there's only 3. Okay, she was one of 3 VA investigators. So this award is the highest honor bestowed by the U.S. government to outstanding scientists and engineers beginning their independent careers. She has over 80 publications which span her major research interests of the epidemiology of infectious diseases, particularly healthcare-associated infections and outcomes related to these infections. The other thing is that she has been an independent investigator receiving federal funding for 7 years now, in addition to being co-I on several VA Merit Awards prior to that time period. She's also been co-director of 2 different research centers at the VA, one focused on spinal cord injury, and a new one, which is our funding is about to start on Saturday, is on the rapid implementation of evidence in decreasing multi-drug resistant organisms and healthcare associated infections. So with that, Dr. Evans.
Thank you, Katie, for that warm introduction, and thank you for inviting me here. I hope you find the talk interesting to tell you a little bit about the work that we've been doing on multi-drug resistant gram-negatives in veterans with spinal cord injury. So first, I will note that I have no disclosures and also indicate that these are the opinions of me and my co-authors and not the VA. I'd also like to acknowledge my co-authors and co-investigators on this study, as well as the funding that was used to complete the work here. So just to orient you to what I'll be talking about today, I'll have a few poll questions at the beginning and dispersed throughout the presentation. Give you some background on spinal cord injury and infection, the objectives of the study that we conducted, the methodology used and the results from it, and also provide you with some information on conclusions and limitations, as well as the next steps and future research we hope to do with this work. And then I'll open it up for questions. So just to get an idea of who is in the room, and we don't have an audience response system, so we'll have to do this the old-fashioned way by raising our hands. So who are you? How many people are pharmacy students here? Okay. Other type of students, public health, what have you? Okay. So a lot more of you. Pharmacy outcomes researchers or faculty here. All right. So everyone separated, all the students over here, all the faculty over here. Any other doctoral level researchers or faculty that are not doing pharmacy outcomes research? Okay. And then any other clinicians that I have missed? All right. So. Right.
Slackers who came for a free lunch.
What's your research focus? Epidemiology, pharmacoepidemiology? Okay, talked to lots of people, right? Health economics or pharmacoeconomics, a few of you here. General health services, outcomes, Katie, right? Qualitative methods, anybody? Lisa Sharp, all right. Any other areas I have not got to? Disparities, all right, great. So a smattering of areas. My final question here is, what healthcare populations do you work with? Hospital or inpatient populations? Okay. ambulatory care, outpatient, and this could be about your research as well, okay? So a few of you there, long-term care or assisted living, right? Rehab or disability populations or any specialty populations, okay, Katie? All right, so I think this is why we do the work that we do, because there's very few people who do anything in spinal cord injury outcomes and health services outcomes research in that area, or with disability or special populations with disability. So why is this important? Why is focusing on the spinal cord injury population important? Well, there are nearly 300,000 people living with spinal cord injury in the United States, and the annual incidence is about 17,000 new cases each year. And you might say that, that's not a lot of people, so why put resources into looking at issues in this patient population? Well, they're highly complex. It's a highly complex condition, and it's a lifelong condition. It impacts function. People have paralysis at a high level of injury where they have no function below the neck to lower level paralysis. And because of the alterations in the physiology and the anatomy of people with spinal cord injury due to their injury, they have a significant risk for secondary conditions and even higher risk for certain conditions than the general population. And even just to highlight further the importance of focusing on this population, you can see here that illustrated here are the lifetime costs of having a spinal cord injury. So if we look at those with the highest level of injury of tetraplegia, and if a person is injured at 25 years of age, their lifetime costs for healthcare costs and living expenses, even just only that, is $4.7 million for just one person. And if we even look at the lowest level of injury here, it's still $1.5 million to care for someone with spinal cord injury over their lifetime. And this doesn't include any indirect costs, such as the loss of wages and productivity. So in the VA is actually the single largest provider of spinal cord injury and disorder care in the United States. And you'll notice here that I added the D on here, the disorder. And that is because the VA cares for people with not only traumatic spinal cord injury, but also non-traumatic spinal cord dysfunction, which includes conditions like multiple sclerosis. They serve about 17 to 22% of people with spinal cord injury in the United States. And in 2013, about 18,000 people received care from the VA. The vast majority of the population in the VA is male, and the average age is 59 years old. Also, 60% of those are injured at 30 years of age or less. So that means that these people are being injured at a young age and therefore living for a very long time with these injuries. So really focusing on secondary conditions, improving function and quality of life are really important. So this figure illustrates the care system in the VA. Care in the VA is delivered through a hub and spoke system where you have 24 facilities that have spinal cord injury centers, and they're called hubs. And they offer specialty care and primary care, and this is primarily where most of the inpatient beds are for spinal cord injury veterans in the VA. The rest of the VA facilities are considered spoke facilities, and this is where there's at least one SCI primary care team located at that facility to care for patients with SCI if they come into that facility. You can see there's actually a pretty big gap here in the West here, which there's actually a new VA facility being built in the Denver area. So many of us are familiar and have heard the media, and if you're not doing work in infections, knowing that healthcare-associated infections are a really important area and focus for acute care hospitals. Over 700,000 HAIs occurred in the U.S. acute care hospitals in 2011. 1 in 25 hospital patients had at least one HAI, and 75,000 patients died in the hospital related to these infections. And the annual direct medical costs are upwards of $45 billion. So a really expensive, high morbidity issue. In SCI, this is even more important because they have frequent infections. The burden of infection in these patients is high. HAIs are estimated to be between 6.7 and 35.5 infections per 1,000 patient days in this population. That's over 3 times what it is in the general patient population. When you look at the most common infections, UTI, in this patient population, it's about 8.9 per 1,000 patient days. And again, nearly 3 times the catheter-associated UTI rate you see in the general patient population. Bloodstream infections, also 6 per 1,000 patient days, nearly 4 times the central line-associated bloodstream infection rate in the general patient population. So clearly, infections are an important issue to address in people with spinal cord injury. And why are they at such high risk for these infections? Well, chronic use of invasive devices. With paralysis comes neurogenic bladder, and urinary catheterization is required. Repeated and long healthcare exposures. They have a lot of healthcare, and so they're exposed to the healthcare environment. And then, of course, antibiotic use. Not only do they get these infections, but these infections have a significant impact on their outcomes. It increases length of stay, and in fact, it's over 2 times the length of stay in someone with an HAI with SCI than in non-infected patients. Increased subsequent hospitalizations, where it's 50% more inpatient admissions than in non-infected patients. And in-hospital mortality is 3 times higher in those with HAI and SCI than in non-infected SCI patients. So a significant impact on mortality and other outcomes. And then to add on to that, many of these infections are caused by microorganisms that are resistant to first-line treatments. And I think this figure really illustrates how difficult it is to be an antibiotic in this world.
What does it say?
So what doesn't kill me only makes me stronger. This is the organism. And man, sometimes I hate being an antibiotic. It's here. One of the organisms that is particularly important and has been causing many infections is multi-drug resistant gram-negative organisms. And we're referring to those as gram-negative organisms that are resistant to 3 or more antimicrobial classes. They have been causing an increasing number of infections, particularly those caused by Enterobacteriaceae like Klebsiella and E. coli, also Pseudomonas and Acinetobacter species. And the CDC data suggests that 13% of E. coli, 17% of Pseudomonas, and 74% of Acinetobacter in ICUs were MDR in 2008. Risk factors associated with these organisms, very similar to risk factors for infection: previous healthcare exposure, long length of stay before the infection, use of invasive devices, and exposure to antibiotics with gram-negative activity. So this issue of looking at antibiotic resistance is not only an issue for the VA or even local healthcare systems, but nationally. The White House issued a national action plan for combating antibiotic-resistant bacteria, where multi-drug-resistant gram-negatives was noted. The CDC issued its urgent threat report, where it had 3 levels of threat, and multi-drug-resistant Acinetobacter was the second highest threat level of serious. Multi-drug-resistant Pseudomonas aeruginosa also had that serious threat level. But the one with the highest threat level, urgent, was carbapenem-resistant Enterobacteriaceae. And even though it is still a very rare organism found for causing infections, we know that people are really afraid of this spreading because of the lack of antibiotics that are available to treat this infection. Also, just to point out, this particular organism is important to the VA. They issued a guideline and policy for controlling carbapenem-resistant Enterobacteriaceae last year. And finally, I just wanted to mention, this is not even just a U.S. problem, but this is a global health problem. And so the United Nations last week had a meeting on a high-level meeting on antimicrobial resistance, where they were focused on making a commitment to addressing this issue. So a lot of people are engaged in trying to address the issue and spread and control of antimicrobial resistant organisms, including these multi-drug resistant gram-negatives. So, question for you. Based on what I've told you, what percentage of gram-negative organisms do you think are multi-drug resistant in patients with spinal cord injury? Less than 30%? Anybody? How about 30 to 39%? 40 to 49%? Okay. All right. 50 to 59%. Okay. So how about 60% and over? All right. So we got a few. We got one person there. All right. Well, let's look. So we have some early studies in the 1990s that showed that about 22 to 33% of gram-negatives were multi-drug resistant. And this was defined as resistant to 2 or more antimicrobial classes. So actually, if you use the definition of 3 or more, it would be a little less than that. But a more recent study led by our dear Katie Suda looked at one VA facility and found that 60% of gram-negatives were MDR. And that was defined as resistant to 3 or more antimicrobial classes. So the literature suggests it's somewhere between 22 and 60%, but these were one-site studies. So our goal was to describe the prevalence of and factors associated with multi-drug resistant gram-negative organisms in veterans with spinal cord injury, and then assess the impact and outcome. We conducted a retrospective cohort study, which included 142 VA medical care facilities and its affiliated clinics. It included about 19,657 people who sought care in the VA during our study time period. We used the VA's corporate data warehouse, and I can't say how much using the corporate data warehouse, which is basically a warehouse of data where all the electronic medical record data comes from every patient encounter in the VA. So it has billions of records. It has information on demographics, medical encounters, labs, and pharmacy data. And so we were able to harness the availability of this data to be able to actually look at this particular question. We also use the VA Spinal Cord Dysfunction Registry and its outcomes database to get at spinal cord injury characteristics, and then the VA Vital Status File, which has information on when people die. So our main outcome was to look at cultures with at least one multi-drug resistant gram-negative organism and whether that organism was multi-drug resistant or not. And we defined multi-drug resistance as resistance or intermediate susceptibility to 1 or more antibiotics in 3 or more antibiotic classes. And just to note, this did not include intrinsic resistance, so it did not include antibiotics where an organism had a natural resistance to that particular antibiotic. We also looked at one outcome so far, which is 30-day mortality, and used the last culture to evaluate that particular outcome. Our statistical analyses were descriptive as well as some bivariate statistics. We did a multivariable logistic regression model for both aims, where aim 1, because we had repeated measures within patients, we adjusted for that. So 19,657 patients with spinal cord injury during the study time frame. 13,940 of those patients had microbiology culture data available, which came to 125,000 cultures. Because we were interested in multi-drug resistance, we had to get at antibiotic sensitivity. So we only included those patients and cultures that had antibiotic sensitivity data available. And so that resulted in over 9,000 patients being included in over 41,000 cultures. We excluded any cultures or multiple cultures within 30 days and where no gram-negatives grew. So we were left with 34,760 gram-negative isolates in 27,897 cultures within 8,677 patients. Still very large sample size. So when we look at the data, the most frequent gram-negative isolates were E. coli at 28%, Klebsiella at 17%, Pseudomonas at 16%, and Proteus mirabilis at 13%. These were the top 4. When we look at the percentage of MDR gram-negative cultures, 41% of the gram-negative cultures had at least one multi-drug resistant organism in it. So you might say, well, how does this compare to a general veteran patient population? Well, we did look at that quickly, and it was 21%. So those with spinal cord injury had a 2 times higher proportion of the gram-negative cultures being multi-drug resistant. And then you could also look at this a different way, where we looked at the actual isolates as the denominator, and it's 36% for gram-negative isolates being multi-drug resistant. When we look at the most frequent gram-negative isolates and the percentage that were multi-drug resistant, Pseudomonas was 20%, Klebsiella was 31%, Proteus mirabilis was 43%, and E. coli had the highest MDR of 54%. So we look at the demographics and unadjusted association of these demographics with multi-drug resistant gram-negatives. Of course, our sample was primarily male. Over 80% of the sample was 50 years of age and older, and older age was associated with multi-drug resistant gram-negatives in the unadjusted analyses. A little less than half of our sample had tetraplegia, so a higher level injury, and had a complete injury, which means that they have no sensation. And tetraplegia and completeness were associated with having a multi-drug resistant gram-negative, so a severe injury was associated with having these organisms. About a third of our sample had been injured for 10 years or less. And we found that shorter duration of injury was associated with multi-drug resistant gram-negatives. And I'll talk a little bit about that in the conclusion section. So some more unadjusted findings. When we looked at facility information and looked at facilities that had spinal cord injury centers and those that didn't, we see that being in a spinal cord injury center had a higher odds of having a multi-drug resistant gram-negative culture. And this isn't surprising since these facilities are where the more complex patients should be going. Also, when we looked at U.S. geographic region, compared to the Northeast, the Midwest and the West had a lower odds of having a multi-drug resistant gram-negative. And this also isn't that surprising when you look at some of the other literature about geographic differences in antimicrobial resistance. One thing I'll note is that the South had about half of the sample and was not different from the Northeast. And we've seen in other work how the Northeast and the South tend to have higher antimicrobial use and higher antimicrobial resistance. So just to look at this in a different way, the red dots are the spinal cord injury, the facilities with spinal cord injury centers across the country. So if you keep that in mind, we look at this. So if we look at by facility, this is the number of isolates with multi-drug resistant gram-negative organisms, where the red dots are where the spinal cord injury centers are, and the yellow dots are where the non-spinal cord injury centers are, the spoke facilities. And you can see that there are a lot of isolates out there in the spinal cord injury centers. Now, when down here, if you look, that's Puerto Rico, by the way. Now, when you adjust for the percentage of patients, so you account for a denominator of the number of patients that they have, we actually see that kind of come down. So if we look at the, about 50, this means that 50% of the patients had at least one multi-drug resistant gram-negative, this size dot. And you can see that some of these spoke facilities actually have a considerable amount of patients being impacted by having a multi-drug resistant gram-negative as well. So this just isn't an issue for the specialized centers, but for many of the other VA facilities that see a nice proportion of spinal cord injury patients. So looking at some of the medical characteristics that happen to be associated with multi-drug resistant gram-negatives, having a culture that was identified in an inpatient setting, and this could include those who had outpatient visits that were subsequently admitted the same day, and also being from long-term care, also associated with having a multi-drug resistant gram-negative. When we look at specimen type, there is no association here, but you can see that over 80% of the cultures came from urine, which we know urinary tract infection is one of the top reasons for infection and top reasons for getting a culture. Polymicrobial culture was associated with having a multi-drug resistant gram-negative, and this just means that more than one organism grew in the culture. In fact, there was more than one gram-negative organism grew in the culture, which is interesting. Pressure ulcers was also associated with MDR gram-negatives, so these patients get a lot of pressure ulcers from the community, not in the hospital. Hospital-acquired pressure ulcer in this patient population is very rare. They come into the hospital, they're admitted because they have a pressure ulcer that developed while they were at home. There are no comorbidity indices that have been validated for use in the spinal cord injury population, but we like to get some estimate of what what a comorbidity measure might look like. So we used the Charleston score, and we can see here that a higher score for Charleston, which means more comorbidities, was associated with having a multi-drug resistant gram-negative. When we look at healthcare exposures, not surprising. Long-term care facility exposure in the past 90 days, an ICU stay in the past 90 days, any hospitalization in the past 90 days were associated with having a multi-drug resistant gram-negative. Mechanical ventilation also associated, even though a small number of people, cultures were associated with that. And then, of course, antibiotics in the past 90 days, which you can see a very high exposure rate in this patient population. 2/3 had exposure to antibiotics in the past 90 days. And this is just another way of looking at the data that I just showed you and just showing you the percentage of MDR gram-negative cultures by all of the different characteristics that we just looked at, where the average is this orange line here of 41%. And so you can see here that polymicrobial culture was pretty high here. So in our multivariable cluster-adjusted analyses, these are the factors that were independently associated with having a multi-drug resistant gram-negative culture compared to those without MDR gram-negatives. Consistent with the findings of the unadjusted analyses, older age, having a more severe injury is associated with having an MDR. It's actually the opposite comparison here, where those with a lower level injury was protective. Duration of injury, again, that shorter duration of injury or longer duration of injury was protective. We still see that significant variation across region, and that the Midwest and the West had a lower odds of having a multi-drug resistant gram-negative compared to the Northeast. In our unadjusted analyses, there was no association between in the specimen type of having a multi-drug resistant gram-negative, but we see here that blood and other specimen types, so it could have been wound or respiratory specimen, were less likely to have a multi-drug resistant gram-negative compared to urine cultures. Again, inpatient and long-term care, higher odds. Polymicrobial cultures, again, way out here, higher odds. Having a pressure ulcer and healthcare in the last 90 days, higher odds. And then antibiotics as well, having a higher odds. So we looked at this and looked at the specific antibiotics and put those in the model. And these are the ones that turned out to be significant or bordering on significance. So if you look at the sulfonamides and the nitrofurantoins, those are common antibiotics used for urinary tract infection. Oops. The fluoroquinolones also. Third and fourth generation cephalosporins, the carbapenems, the colistin, often used for gram-negatives. Not a whole lot of carbapenem use, which is good. But still associated with having a multi-drug resistant gram-negative. And then colistin, very rare use, but bordering on having a significant association with having a multi-drug resistant gram-negative. So again, these are kind of these last resort type of antibiotics that you have to be able to treat some of these types of infections. And again, I just want to remind you, we looked at cultures, not infection. So this could have been infection and colonization, what have you. So it's a limitation. So back to, if you remember the question I had for you before, I said, what did you think it was for SCI in general? What percentage of gram-negative organisms are multi-drug resistant in veterans with SCI? So have you been listening? Less than 30%? 30 to 39%. 40 to 49%. Okay, we got one person too. 50 to 59%. 60% or more. Okay, so so the cultures, 41%. So for veterans with spinal cord injury, what we found across the nation is that 41% of the cultures had at least one gram-negative organism that was multi-drug resistant, and 36% of the isolates were multi-drug resistant. So outcomes, who cares? Why does this even matter? Well, we looked at one outcome.
Were we all wrong?
Yes. There were two of you who were right.
You start over?
I will say you might have gotten caught up because Katie's paper shows 60%, so that's where people, yeah. So, but that's the facility variation. Overall, this is what it is, but at least one facility had a proportion that was 60%. So we looked at death within 30 days of the last gram-negative culture, and we saw that 4% of people who did not have a multi-drug resistant gram-negative died compared to 7.2%, which gave us an odds ratio nearly twice the odds in the multi-drug resistant group. However, when we adjusted for all the demographics, injury, and medical characteristics, it came down to 1. So there was no significant independent association of having a multi-drug resistant gram-negative and having an adverse outcome of death within 30 days using the last gram-negative culture. So we know that these patients die from a lot of other reasons. And also, we did not look at infection, particularly. We have both infection and colonization in here. So if we had tried to get this down to a sample that was truly infected, we may have found something different. So in conclusion, multi-drug resistant gram-negatives are more common in veterans with SCI as compared to the non-SCI patient population. And older age and more severe injury characteristics are associated with multi-drug resistant gram-negatives. And we found that longer duration of injury was protective, and there is some evidence out there that the immunity of SCI patients against bacterial invasion gets stronger over time due to their repeated infections. Another theory that was brought to me by an SCI doctor was that many of these people who have been injured for a very long time got sphincterectomies way back in the day. And so they don't get UTIs and thus don't get a whole lot of infections and thus aren't getting antimicrobial resistant organisms. I don't know, that's left up for discussion and exploration for that particular reason. We also found that there was significant variation across regions and facilities. And this is consistent with general acute care studies that have shown that there are differences across patient populations, there are differences in antimicrobial use patterns, and in infection control practices that could be impacting this. Also, I think an important point for even looking at this is that being able to know your numbers and benchmarking, to know where you're starting and where you need to end in terms of any interventions that you need to focus on for preventing and controlling these organisms. We found that polymicrobial cultures was a strong factor associated with these organisms, and this was independent of urine cultures, even though those are often associated with polymicrobial cultures. Polymicrobial cultures have also been shown to be a factor in inadequate antibiotic treatment, but we did not look at actual treatment in this study. So I think with the issue of the polymicrobial cultures is that there's an opportunity for spread of resistance between organisms and passing genetic material between each other. So I think that's of concern for this particular patient population. Healthcare exposures, including being in long-term care, were important risk factors, and I think this emphasizes the need to continue to focus on infection control. At least in the VA, the spinal cord injury centers are complex environments. There are a lot of common areas. If the patient is not that sick, but still in contact precautions, they can leave the room and go about the hospital and go everywhere that they want. And so there is some discussion around the efficacy of the cleaning and environmental cleaning in these units because these patients are going everywhere. And I just like to point out that I was at a meeting a couple of weeks ago at the Paralyzed Veterans of America Summit, and there was a poster from Curtis Donsky in the Cleveland VA where they were testing a UV disinfection machine. And prior to the disinfection, they sampled all the wheelchairs in the spinal cord injury long-term care unit. It found that 45% of the wheelchairs were contaminated with MRSA in multiple places. And this was just MRSA. They didn't look at any other MDROs. And so I think this just represents that we have no idea what the bioburden of these organisms are in these common areas, and therefore, and even on wheelchairs and equipment, and therefore really need to focus some attention on interventions to improve infection control and environmental cleaning. Antibiotic exposures were important factors, and definitely reductions in misuse of antibiotics. We know from other studies that have been conducted that often these patients don't truly have urinary tract infection. They have asymptomatic bacteria, but are still treated. Dr. Suda's paper that just came out not too long ago in JAMA showed that and gave a conservative estimate that there is an opportunity for a 30% reduction in annual antibiotic prescription rates in the United States. And I'm suspecting that that's probably even higher in this patient population. So I think there's a definite need to focus on antimicrobial stewardship in VA spinal cord injury centers. Even with all that, we didn't find a significant impact on 30-day mortality using that last culture, but other factors are strong predictors of mortality. So some of the limitations are that we lacked medical information on encounters that occurred outside the VA healthcare system. We had limited information on invasive devices. We would have had to do a more in-depth extraction of the data in order to be able to see what type of devices people were using in days on those devices, which would have required more sophisticated extraction techniques like natural language processing. We also, as I said before, did not distinguish between infection and colonization and did not account for treatment. However, this is the largest system of care for veterans with SEI. The electronic data warehouse, no one else has. So we can do this in SEI, we can do this in other patient populations, we could do this in veterans in general, but no one has the breadth of data available to be able to look at these types of questions like it is in the VA. So I think it's great that we have access to it to be able to answer these really important questions and improve healthcare quality in veterans. So for future research in this particular area, we're hoping to evaluate the differences across the clinical settings, inpatient, long-term care, outpatient, focus on specific organisms, CRE, Katie's working on that CRE paper, distinguish between infection and colonization, and assess treatment outcomes and identify optimal treatments. We know that there are no specific guideline recommended treatments for certain multi-drug resistant gram-negative organisms, and people are just using, combinations of things. Also, that there was significant variation by facility and region. So being able to know where the issues are, we would like to identify opportunities to be able to focus on interventions that reduce spread, either through antimicrobial stewardship and or infection control activities. So that is it. Thank you. That is my contact information. And any questions? Yeah, I do. I think it was the rationale behind using the last culture. So you notice that I kept saying last culture. So interesting, right? Because you can only die once, right? So we had to decide which one to use, the first or the last. We found that we got very different findings in using the first culture. And I think this has something to do with probably that level of the survival of having some immunity over time. Those people, when we used the first culture, it actually had a even protective effect. I didn't explore it that further, but at least we know we're only getting people who survived in the last culture, and thus, when we look out 30 days, we can say something about that particular time period. But we did get different findings when we used the first culture, and we still need to explore more. What does that mean?
For the future research, what type of design do you see with a smaller sample, perhaps primary data collection, to determine the difference in the infection versus the colonization?
So we've been developing methods to distinguish infection versus colonization. One, we have to do it by each culture. figuring out UTI. So we've been doing some primary data collection in terms of actually going into the chart to look to see what did the provider think, and also looking at all the test findings to come to our own conclusion whether they truly had an infection or not. So it is difficult. I mean, we've been using a bunch of different combinations of, looking at UTI diagnosis and UTI treatment. Well, we know that it may not truly be a UTI, and we know that even if they got treatment, it may not be truly a real urinary tract infection. So we've been trying to do a combination of chart review and really will extrapolate from that on the samples that we've used for that.
So you identify an infection only the sample has been collected. Is there a difference in terms of sample collection across VA institutions? Are you considering like prospective sample collection or like systemic sample collection in patients even without symptoms?
So your first part of your question was, is there a difference across VAs in how they collect the data electronically?
Collect the samples to test the...
Oh, yeah, totally. Totally. So one VA, we always say one VA is one VA, basically, even though it's an integrated healthcare system, and technically they all have the same electronic health record. One, VA facilities have the ability to change it. Some facilities are like hubs for labs, so all their labs get sent to that one facility. So Hines is the hub for Jesse Brown, which is right down the street, and for some place called Castle Point, which I have no idea where that is, but they get all their labs. So whatever the practice is there, right, they're getting those. That's what the practice is for the rest of those places. Then you're talking about provider level practices that are difficult to figure out based off of electronic health record data, which is then where you have mixed method studies to really help you learn about what are people actually doing, whether it's surveys or whether it's interviews or what have you. So I think to answer your question is there's lots of variation in how data is collected and in provider practice on what they actually do. And so we've, in trying to understand some of that facility variation, we actually tried to include a random effect for facility in the model, and it didn't make a difference in our findings at all. So we actually stuck with a more simpler model, which was adjusting for the repeated measures within patients, which seemed to account for the vast majority of the variability that we saw. But I think that's a really important question, and one that we struggle with in using this data effectively because of the variation in practice across VA facilities. And even sending out cultures for sensitivity testing. We don't know all the reasons why some cultures are sent out and some aren't for sensitivity testing. And if we don't have that information, we can only use what was, the results that came back for the sensitivity testing for that.
Were there any subgroups where that mortality association was significant, like oldest age group or most severe?
So I did not go that far. I did not go that far. So you mean like stratifying by subgroups to see? So no, I did not go that far. I should have brought the models, but the highest predictors: age, duration of injury, having a pressure ulcer. Trying to think what else. Being an inpatient or in long-term care. So those were the high predictors of mortality based off of that. But we have more work to do on the outcome. So we're going to be looking at length of stay, trying to tease out where we look in terms of the spectrum of the patient and having these from first culture, the last culture, and what does that mean?
Wow.
Oh.
I'm not sure how to get back there.
Let's see.
Click on that.
This.
Or the very bottom.
Oh, okay, got it.
It wasn't a long one. Look.
Oh, so the question was it based on cluster, based on region or facility? It was actually based on patient. So again, the facility effect did not explain the majority of the variance. It actually was the patient that explained the majority of the message. Oh, great.
I was wondering if you could talk about how the SCI prevalence in the private sector and how the system of care is structured in the private sector. So how this work at the VA may impact private sector patients.
Well, the one thing about the VA is that we see chronically injured patients, whereas in the private sector, the model systems is the big system of care that does a lot of work and outcomes research in spinal cord injury. They have a great set of data. They do a lot of primary data collection, but they don't follow their patients up over time. They try to, but they lose a lot to follow up. They also have mostly patients who are acutely injured, so patients injured in the last 5 years. So the differences between the two systems really is that they're really focused on acute care patients, and we're really focused on primarily chronically injured spinal cord injury patients. So, but there is this, not a whole lot being done, as far as I know, in the model systems in developing interventions to reduce HAIs and antimicrobial resistance in this patient population. So I think that there is definitely room for focusing further in this area in the model systems.